Hello?
Hello? Hey folks, if you're just joining us for the AHSQC webinar, if you'll go ahead and mute your microphone. Thank you. All right, folks, why don't we go ahead and get started? I'd like to go ahead and welcome everyone to our Quarter 2 web collaborative meeting for the AHSQC. This is Ben Paulos. We've got a lot of exciting things happening. Things are happening pretty rapidly. And so again, thanks for your patience, and let's get started. If everyone can go ahead and use web audio if you can, and also, once again, just a reminder to mute your microphone so everyone can hear okay. If you have any issues or questions, you can use the chat function of Skype here and go from there. These are our disclosures for Mike Rosen and myself. Most notably, we are employees of the AHSQC. And I would remind everyone to please no reproduction of the material in this presentation without the approval of AHSQC. And I will also let everyone know we are recording this webinar for later presentation, which will be available on our website at ahsqc.org. So our topics today are the following. First of all, thought it would be good to go over how are we doing as a collaborative in terms of where we are, some of our outcome measures. A brief chat about our focus on follow-up initiative, a little discussion on integrating patient-reported outcomes in your practice, and to introduce our initiative of No Hernia Left Behind. A couple of words about our data assurance process, some upcoming user interface changes, and also we'll have an open forum to discuss any issues you might have that have come up. So overall, how are we doing? Pretty well, actually. We currently have 208 surgeons, 282 sites. There you see our site map there. And what I think is really exciting are the following two pieces of information. If you look at our number of patients entered each month, it continues to go up. Most recently, in June of 2017, we're entering just about 1,400 patients per month, which is really, really exciting. And also, there it is, just under 1,400 patients in June 2017. And then if you look at the cumulative number of patients entered each month, just recently, we've crossed the 20,000 patient threshold about 2 weeks ago. This is really, really exciting. Want to congratulate everyone on their hard work, and it's really impressive that in the past few years since our start, we've reached the 20,000 mark already. I should note that over the past 4 months, we've been collecting information on inguinal hernia patients, and we have currently 1,881 inguinal patients. I should note, if you are having some trouble seeing the slides, the best thing to do is to try and download the Skype app. The web application, we've been having some difficulties, but if you can't see the presentation itself, we'll have it available later on for viewing on the website. But again, download the Skype app or the Link app on your device, and that should make things a lot easier. Congratulations also to the following surgeons who have 100% 30-day follow-up completed. There are several of you. It's nice to see that we have some new names here, a lot of folks in private practice. Again, congratulations on this. I think this is really one of the keys to our success is short-term outcomes. And our current rate is about 84%, and this is across upwards of about 14,000 patients. So that's actually, it's really good. And our goal still is 100% 30-day outcome, 30-day follow-up completion. We've had a lot of success in terms of publications. Here are just a couple of examples of our most recent and kind of most impactful publications. I should note that that last one down there is there an association between surgeon hat type and 30-day wound events following ventral hernia repair. When that got posted on the General Surgery News website, it actually crashed the website for about 3 or 4 hours. So we're particularly proud of that. Our journals that we've been publishing, these manuscripts are the top tier surgical journals, Annals of Surgery, JACS, Hernia, Surgical Endoscopy. And I should note that this isn't just for a select few people within the QC to publish, and most notably Mike and myself. We want everyone who has an interest in publishing, especially our private practice colleagues. All you got to do is you can access the AHSQC data. Just go to that website there, ahsqc.org, and select data, and there will be instructions on how to access the data. If you don't have a biostatistician or an IRB, we can provide that for you. And so there's a lot of ways to get our data and our message out there. What about for MIPS, MACRA, QCDR? Well, if you aren't familiar with those letters, you probably should get familiar with them because it's going to affect how you get paid, especially for your Medicare patients. We're approved for 2017 by CMS to avoid penalties and start the incentive program there in terms of outcomes. This is really useful for private practitioners because oftentimes you don't have many other ways to avoid these penalties, like a lot of folks like myself at these tertiary care institutions. We're going to send out more information about this next week with an FAQs. Shelby Dunstan, part of our AHSQC team, has done a fabulous job putting this all together. So if you're confused about it, how the AHSQC can help, there'll be more information coming next week. I just want to take this time real quick to say congratulations and thanks for our patients, our surgeons, our institutions, foundation partners, and also I want to single out as well the United States Food and Drug Administration. As many of you know, they're on our executive council. They really have been a great resource and partner in terms of making the AHSQC a success of what it is today. So again, thanks everyone. These are our current foundation partners, our platinum level foundation partners, Intuitive Surgical. Our gold level foundation partners include Allergan, formerly LifeCell, Bard Daval, Medtronic, and also our recent silver level foundation partner, Gore. Well, what about our outcomes? Thought it would be good to kind of share exactly, well, how are we doing as a collaborative overall? Well, these are our 30-day surgical site infections over time, over the past few years. And these are all comers, basically all the operations we've done to the QC. This is roughly around 14,000 operations. And you can see our infection rate actually has gone down from about 3.7% to just about 2.6%. And if you look at our surgical site infections for our open retromuscular sublays, again, it's a smaller group of patients, but overall you can see we hover around the 6 to 8% range for SSIs there. And then if you look at the surgical site occurrences that require procedural intervention, for example, perc drains of seromas, opening wounds, all the way to mesh infections, that sort of thing, removal of meshes. Overall, we've gone down from about 6% to 3.9%. And if you look at this in our retromuscular population, we've been hovering around the 8 to 12% range, and overall looks like it's coming down a little bit. So I think it's great, just the fact that we're able to track that information and share it with you in and of itself is awesome. The fact that it's actually gone down since our inception, I think, is a double advantage here. So well done for everybody. One big part of the AHSQC is our focus on follow-up. Everyone on this call knows that quality in terms of hernia outcomes doesn't stop at 30 days. It certainly involves looking at things 1 year, 2 year, 3 years. And so over the past year, and really from here on out with the Quality Collaborative, we're really putting a focus on long-term follow-up, finding strategies and solutions for this, seeing what works, what doesn't work. I should remind everybody, if you think about this in terms of kind of what we consider the gold standard of looking at following patients in a randomized controlled trial, something like that, or a prospective trial, if you look at that, you kind of anticipate 70 to 80% follow-up, and then every year it goes down after a while. That's in the best case scenarios with millions of dollars available to you. So we're going to try to achieve that goal. Probably won't come that high, but again, we've got to try to get this and show you some results on that. The way our follow-up works from a long-term standpoint is really kind of based on two things. The first is follow-up in your own routine practice. For example, myself and a lot of the folks in the QC, we'll follow our abdominal reconstruction patients at 6 months, 1 year, 2 year, and 3 years. And I'll kind of show you how you can enter information just at each one of those visits. But that's really one quick way of getting long-term follow-up overall in the QC. The other way of doing that is by targeted follow-up with the AHSQC. We've just launched an initiative where with a specific population that we're interested in to get long-term follow-up, we can obtain long-term follow-up via our patient-reported outcomes through our AHSQC personnel itself. So very simply, when you're seeing your patients 6 months, 9 months, a year, 2 year, 3 years, all you have to do is go to the user interface and go to the additional follow-up tab. And it's very similar to the 30-day follow-up. I just timed myself on entering this for a single patient, including login. It took me, on average, 12.2 seconds to do this. It's really easy. It's very, very quick. And everyone knows how critically important it is to get this long-term follow-up. So if everyone was able to do that every time you saw a patient, it doesn't have to be you. It can be your nurse practitioner. It can be another practitioner as well. It's really, really key we get this. What about some outcomes for long-term outcomes in terms of our myofascial release patients? So we just kind of ran this to give you an example of the power of what we're able to do in terms of evaluating patients and looking at long-term outcomes. Again, not just 30-day outcomes, but long-term outcomes. So if you look at the patients who've had various forms of myofascial release performed, it's just over 4,500 patients in our collaborative so far. And to give you a little bit of a feeling of what those patients, who those patients are, what they look like, the median age is 59 years, about 54% women. 46% had recurrent hernias, mean hernia width of 10 centimeters, history of abdominal wall SSI. Again, specifically an abdominal wall SSI is 26%. Median BMI is 32, diabetes 21%. I mean, you take a look at that list there, these are complex patients that we're all operating on. And certainly, you know, this is probably reflective of those in the QC being experts in their field and handling a lot of complex scenarios. But again, this is a pretty overall morbid, complex population. 29% have had subcutaneous flaps raised, kind of looking at some of the operative information here. TAR was performed in 60%, sublay mesh 90%, and out of those sublay meshes, overall about 80% were retromuscular. Concomitant procedures, 31% had a concomitant procedure performed. Fascial closure techniques, fascial closure was achieved in 96%. Absorbable suture and in a running fashion was by far the preferred method, with figure of 8 performed in 18%. So it kind of gives you a feel of what we're doing in these complex patients. Well, I think this is really, really important. Here, I will tell you, this is the first time we're releasing recurrence data long-term. This is overall composite recurrence. And what that means is recurrence measured either by physical exam and that additional follow-up, by radiographic evaluation, ultrasound, MRI, or CT scan, or by the bulge question in the ventral hernia recurrence inventory. If you ask a patient, do they have a bulge? So our overall composite 1-year recurrence after myofascial release, ventral hernia repair with myofascial release, is 13%. I think that's a realistic number, and that's just over 1,000 patients. And look at our 2-year recurrence. Again, we don't have that much comparative information, but not too bad with 258 patients. It's about 22%. I think this is believable info. So if you just kind of take a pause there and look at that, I mean, I think we're capturing real data in a complex population. And it's a really, really compelling thing that we're able to capture this information. And let's kind of go one step further. Are we actually improving these patients' lives from a functional abdominal wall standpoint? And so if you look at our Hercules scaled score, which is basically rating abdominal wall function on a scale of 0 to 100, 0 being the worst function, 100 being the best, our baseline median Hercules scale score for this population is 47, which is about what we've seen overall. At 1 year, the median Hercules scale score did improve to 56, and at 2 years, it's preserved at around 57. And I think this is really important because the story this tells us is that although our recurrence rate is going up, we are finding that by repairing these patients, overall we are improving their quality of life. And it looks like, at least from 1 year to 2 years, in a limited fashion so far, given the patients we have, it looks like we're improving their quality of life and it's remaining high relatively. So a couple of other quick points about some initiatives coming down here. We're going to start a phone number entry incentive program for targeted long-term follow-up to help us with this. From the beginning of the collaborative in July 2013 to about January 2016, we didn't collect phone numbers. We're going to start an incentive program to enter phone numbers for those particular patients. And we'll have more info about that later on. And what I thought we'd talk about now is have a discussion amongst the practitioners on the call, and certainly anyone's able to put input on this, how you integrate your patient-reported outcomes in your practice. And this is important because we're finding that our email engagement isn't exactly what we'd like it to be. Despite us collecting about 60% emails, people just don't like emails, don't like clicking on the links and filling out all the stuff you got to fill out. So a lot of practices, myself included, have incorporated collecting these patient-reported outcomes forms at the time of their clinic visits. I thought we'd pause here and just kind of open it up for anyone to discuss how they've really implemented this in their own practice. Or if you have questions on how to do this, let's go ahead and bring that up too.
Ben, this is Mike. I'll kick it off. I think this has been something, and honestly, I struggled with for the first year or two because it somewhat felt overwhelming, and I just kind of relied on emails, and there was a lot of logistical hurdles to figure out at what level, was it a secretary, a nurse, or myself, or the residents, who was going to figure out who was getting what questionnaire. But we've actually, for about the last 6 months, have really come up with what I think is the ideal and pretty straightforward situation. Actually, Luciano, who's our research fellow from Brazil, is on the call too, so he can chime in if he wants. But basically what we did is, if you read the questions carefully, the inguinal hernia questions and the ventral hernia, Hercules, promise, and even post-op, the ventral hernia recurrence inventory, are not ventral or inguinal specific. They're either abdominal wall or hernia kind of centric, so they work for everybody. So what we have done is, in our practice now, every patient preoperatively gets the Hercules, promise, and the inguinal hernia questionnaire for everybody, whether they're ventral, inguinal, or whatnot. It's printed on one piece of paper, and the nurse hands it to every single preoperative patient during our teaching, and we collect them, and it really only takes a couple seconds to put it in once they're into the QC. But more importantly, it was probably really the key, for us at least, is post-operatively, every patient gets the inguinal, ventral hernia recurrence inventory, Hercules, and promise. Whether they're inguinal, ventral, peristoma, epigastric, it's on one page. It's a post-operative form, And on the back end, when we fill it in, it's easy to figure out who got what operation. But we basically, at the beginning of our clinic, at the front desk, the secretary has a stack of everybody's name with a sticker on it that our nurse did in the prep for clinic, and they hand it to patients while they're in the pre-op area or the waiting room. Fill it out, they hand it to our nurse when they get in the room, and it's done. And doing that, I think we're probably over 95 to 99% compliance, and it's just using our infrastructure. So, Luciano, I don't know if you want to chime in if there's any other kind of key facts in what we did that I might have missed.
Well, I believe most of the nurses have been 100% compliant. This fact that everybody answers all the questions made everything much easier. So you just need later to figure out if this is a ventral hernia or this is an inguinal hernia, and then you need to input the data in the QC, which doesn't take more than 20 seconds to enter those patients' PROs. And now I believe we're pretty compliant with all the PROs, and I believe more than 90% of the PROs are being put in the QC.
So I don't know if anybody else has any other kind of ways, but to me it's been a game changer because we were not that compliant, and now we probably won't talk about it, but this has allowed us now for some of the randomized controlled trials that we're embedding in the QC. It becomes part of our standard practice, which really, really, really makes this kind of a game changer for us too, and no kind of extra work because everybody's getting it. And just until somebody chimes in, for us, the hard part was my nurse in clinic could not kind of have the time, figure out the effort, who was an inguinal, who was a ventral, which one do I give what to, and it just seemed overwhelming to him. So once we made it that just post-op patients get this, it really made it pretty straightforward.
Yeah, hey, this is Ben. So we had a little bit of a different experience at Vanderbilt. So we had one of our nurses really kind of took this upon themselves to implement this in our clinic in the hernia center, and she just basically took this over and was able to implement it so that the inguinal patients and the ventral hernia patients got things separately, both pre-op and post-op. I'll admit, though, it was a bit of a struggle to try and get that all worked out. But the nice thing we've noticed is that, I don't know if anybody else has this problem, but usually patients are waiting for me for a long time, probably too long. And while they're sitting in the room, we have them fill out the PROs on a paper form. Those are all available on the AHSQC.org website under resource. Once you log in, if you go on the left side, there's a little, it looks like a little book icon. It's the resources. They're all available there. And we stamp it with our patient identifying information, and then we scan it into our medical record. So it's nice because patients get to fill that out while they're waiting for me. And we've been pretty good in terms of our compliance, probably upwards of about 80-85%. So yeah, it'd be great to hear other folks if you've had similar experiences, your struggles, frustrations with this, or we're not even doing it at all and are ready to do it.
I would tag on one thing that Ben said. If you scan it into your electronic medical record or your chart, you can check with your compliance people, but I'm almost 100% certain that ups your E&M code by 1 point, because that's doing a quality of life assessment, which counts as part of review of systems. So if you're billing a 3, it makes it a 4. If you're billing a 2, it makes it a 3. By having patients do it and that you saw it. So there is some kind of payback at the end for making this part of your routine.
Huh, I didn't know that. But anybody else, any thoughts on that? Okay, great. Let's move on. But again, think about that. It's a really important part of what we're trying to track here, because the sole fact that we're able to tell you this information about abdominal wall function after abdominal wall reconstruction, I mean, that's huge. And if this is something we can really make it a point to collect in our routine practice, it really helps the whole effort out in terms of our long-term outcomes.
Hey, Ben,
yep.
Let me just tag one quick other thing. If you guys, whoever's on the call, who might be struggling with this and kind of doesn't want to talk about it amongst the big group, if you either email me or Shelby, we'll get Luciano to put up, and we can even put it on the website, what we do, which is basically just a front and back page PDF of all the questions pre-op and all the questions post-op, and then it makes it mindless for you.
Great. Oh, hey, Mike, can you type in your email address on the chat thing?
Yeah, it's Ben Paulers at Vanderbilt.com.
I was going to say, if you have any issues with the entire AHSQC, please send it to Rosen's email.
Yeah. Anything that you're happy with, please send the email I'm about to put. All complaints will be rerouted today. So I'll put it on real quick.
Perfect. Couple of final things. Our AHS president, Alfie Carbonell, basically tasked us a couple of months ago to capture abdominal wall disease experiences for every patient. And what we had been doing is really kind of limiting the entry to one patient and one hernia per entry in our data collection. Well, he initiated this philosophy of no hernia left behind. And so we're going to try and do this. And over the next couple of weeks, we'll show you how we're going to capture basically the entire hernia disease experience for a particular patient. So you can basically enter everything that happens to them in terms of their hernia disease. Just to give you an example, say you operate on the patient, you enter them in the QC, they recur after that, and then you operate on them again. How do you handle that? What do you do? And we'll show you that. The other common scenario is, say you do an abdominal wall reconstruction on a patient 2 years ago. You're following them in the QC, and then now they have an inguinal hernia that you are going to fix from an anterior approach. How do you enter that patient and capture it? We're going to figure out, we have figured out a way to do this, and we will be sending specific instructions over the next several weeks and show you exactly how that's going to work. But just keep in mind that the No Hernia Left Behind initiative is coming down the way as well. Our data assurance process is critical to the integrity of the data we collect. And just to kind of remind everyone of this process, which is continuing on an ongoing basis, we target to review each site every 3 years. If you're contacted, don't freak out. It's part of the usual process. Everyone gets this. One of the critical components of this is you need to identify a surgeon outside your immediate practice with access to your EMR and your patient records. For example, when I do this, I usually hit up some folks from our surgical oncology division, and what they'll do is they will basically look up your patients and check and see if what you entered in the QC is what's actually in the medical record or your intent. There's a completeness and an accuracy component. The completeness component will directly interface with your billing folks about whether or not you entered all the cases that are supposed to be entered. And then the accuracy component is that other surgeon helping you out. It's actually a pretty easy process to go through. It's handled by a couple of folks at the AHSQC. So when that comes down the pike and comes your way, please help us out with that. It's absolutely critical we do that.
Ben, this is Bob Fitzgibbons.
Yeah.
There'd be other people that could do this other than physicians. For example, a research manager or a PA, and I would think you'd get much better compliance if that was allowed, especially like a research manager. That's what they do. They abstract charts.
Right. Thanks, Bob. So if everyone didn't hear that, so basically the question and comment is, who all can enter data for any part of the collaborative? And abstractors, research assistants, nurses. So every practice is going to have your different solution. Now, we do allow abstractors and nurses and nurse practitioners, PAs, MAs to enter data. In fact, we encourage that because part of the philosophy here is to capture this quality information at the point of care. Now, we do realize, though, a lot of folks will utilize abstractors, and that's okay. The thing you got to be careful about there is making sure, of course, the abstractor knows your practice and knows kind of your terminology in the medical record. The most difficult thing we've found in terms of abstracting is the operative detail. We do ask that the surgeon enters the operative detail at minimum. Some folks still have abstractors that do that.
I'm not talking about I'm talking about doing the audit.
Oh, doing the audit. Sorry. Okay.
Ben, I think to answer, Bob, I think to answer your question, that's fine.
I know how important audits
are.
Oh,
yeah. Gotcha. Mike, go ahead, speak. What you got?
Yeah, I think, Bob, to answer your question, I think that's fine. If you don't have, I think it's perfectly fine to have, we've had research fellows do it, research coordinators. I think it's somebody who you have deemed as qualified to look in the EMR and understand where to find the clinical information, but if not somebody who's in the AHSQC, I think we're totally fine with it. But, right, Ben?
Yeah, no, that's correct. If you do use a trainee, our ask is that it be at least a PGY 3 or above, just because there's obviously technical things that type of trainee would understand. But yeah, I think anyone that you think would have a reasonable grasp of that will work.
Well, I mean, you're doing things like trying to see if you checked hypertension, is that documented in the record somewhere? Well, that's what abstractors actually do, because those audits don't require much medical knowledge. I had to do the practically 100% source checking in that watchful waiting trial because it was NIH funded. And so I know what a burden it is, and it's hard to get busy docs to do this kind of thing.
Yeah,
go
ahead.
Let's come to resolution about this, Ben. Let's come to just so that we make a clear message. I don't find any problem whatsoever for the data assurance process. Whoever you deem is a reasonable person that can understand it, and I agree with you. Research managers are the best at this. Compliance people are the best. That's what they do. So if that's the person you deem is possible to do it and they can abstract that, that's fine for the data assurance. Well, I think just to make the message clear, what we were talking about, I think what we crossed over on was putting in the information in the QC, the operative page we like to be done by surgeons, is just a lot of specifics and hard to abstract.
Yeah, I would agree with that completely. I'm talking exclusively about the source checking.
Yeah. Ben, you agree with that, Ben?
Yeah, and that's been consistent with our practice. And so, Bob, thank you. I actually should have not said surgeon. It can be anyone as we described.
Okay.
Great, thanks. And again, really critical we do this. And if you do use anybody, of course, doing this, they will sign an attestation to the truthfulness and the just kind of more of a moral compelling of that review. So no, that's great. A couple of user interface changes coming. So we've had multiple discussions with Arbormetrics, our data vendor. Many of you know that about 3 months ago there was some slowing down in the user interface. That we've had a couple of workarounds for that. They actually completely retooled their servers. And we got a little bit glimpse of that a couple of weeks ago. It's actually much faster. You're not talking, it's amazing the small amounts of changes just with a click here and a drop-down list there that adds up. So if you look on paper, it's kind of a small change, but anyone who's been entering data in the QC will immediately notice a change, and we're hoping that goes live in a couple of months, and you'll notice that. So really the point is to increase responsiveness and decrease the load times, especially on the patient list. That's actually going to be sped up a little bit too. So that really wraps up the presentation for this Q2 call. And I thought we would just kind of open things up for any kind of wrap-up issues and any thoughts anyone has. And, of course, all the foundation partners on the call, please, we'd love to have you give input on things. And let's go ahead and just kind of open it up for a chat.
He had closely that brought me with the repair of his gastric house. This is local repairs of his stomach colon. He returned to his home in Cleveland to recover. He saw Dr. Gowles on July 13th.
I think somebody's dictating.
What's that?
CAT scan.
I'm getting some background noise. I think someone's dictating right now with their speaker.
Yeah. If you're not speaking, go ahead and just mute your microphone. It'll help us out. Mike, any other thoughts?
Yeah, I mean, I think, overall, kind of from my perspective, I think we're doing a phenomenal job of 20,000 patients. I think we're kind of at a critical juncture where we're getting on the radar of some kind of heavy-hitting organizations and teams and such. I think we didn't spend a lot of time talking today about the QCDR, but I do think you'll get an update from us on that, and that's a really important kind of value add for our surgeons. I think that there's a lot of confusion around that, as obviously there is healthcare in general, a lot of uncertainty. But from all the research and everything we understand, it's not going anywhere. And unfortunately, especially for community private practice folks, there are large penalties looming starting next year that you're being measured for this year if you don't participate. So for those who are doing this, it's a very easy kind of administrative thing to overcome. So we're really hoping that some people will take advantage of that opportunity. And then I think, we're trying to take it to the next level. I think we have 20,000 patients, and we're going to really try and push hard for long-term follow-up. We're going to try and leverage as much as we can everyone to get the phone numbers and start calling and getting some of this information, because I think we have certainly established that we have 30-day outcomes as good as any other registry of data. But to push together to get quality of life and understand what's happening to these patients is absolutely critical. And we just want folks to stay engaged. And actually, maybe the last thing I'll kind of talk about is the data entry aspect and the definitions and kind of how we work to make sure that it is as comfortable as a user interface as we can make it, while also collecting enough relevant information that we can really answer these questions. And so, as you can see, we made changes with the wound closure. After we analyzed it, we couldn't find some differences. But we have some new things coming out. We're going to be looking at Botox, chemical component separation, and some other kind of cool, exciting things that we'll be able to hopefully get some interesting long-term outcome on. So I think if anybody on the call has any kind of pressing things that they think they want to have put in the QC, or other things that they would like for discussion items of things that seem onerous and don't want to have in the QC, this is a prime opportunity to make this call kind of worthwhile as well to you.
Yeah, that's great. And just a couple of reminders. So we're going to have the usual AHSQC session at the American College of Surgeons meeting in San Diego. I believe it's the third week of October. We'll be sending out some more information in the coming months about that. If you're going to be at the ACS, we'd love to have you. That's usually a pretty well-attended thing. There's one question here. Is there any way to have a standard educational module for staff to learn? Oh yeah, that's actually, Jamie, I'm glad you brought that up. So the best way to standardize data entry and familiarity with that is really to go to the videos that are on the website. If you go to AHSQC.org, and I believe it's under the FAQs, at the bottom of the FAQs page, there are about 6 or 7 videos. I've had my staff review it, and that certainly is very, very helpful. The downside is you have to listen to Rosen for like 8 minutes and see him, and if you can tolerate that, you'll be okay.
I can't even watch it. I can't even watch it myself. But just real quick though, it's before you log in, just because some people have had trouble with this. It's on the main AHSQC.org page. And on the top left, it's the FAQs, and then the very bottom, there's a bunch of videos. And importantly, some of these videos are really kind of how to make things more efficient, how to do PROs, stuff like that. So, but you are stuck with me, for sure.
One other point about that. So we're going to actually require completion of one of the modules there, kind of the overview, and we'll be getting back out to all the users to attest to completion of that, more kind of as documentation of compliance of training. Many of you have been looking at the site itself, but we're going to kind of formalize that a little bit. So thanks for bringing that up. That's actually really important.
Hey, Ben, I got another thing just to mention to the group. Mm-hmm. As we have our collaborative meetings in person, in particular at ACS and then next year at the AHS meetings, one of the things that we kind of work together at the executive kind of council level, and particularly Ben and I, is coming up with questions that we can analyze, and we have a very robust analytic team now that we would like to present to the collaborative. So if anybody on the call wants to kind of take a lead in one of those and wants to be the presenter, because we try and spread this out as much as possible, please reach out to Ben or myself or Shelby. And if you have a question that you want to answer, we can go through the data process. But if you just want to be involved and maybe want to give one of the presentations, we have several kind of agenda items that we would certainly like to get folks who are putting all the time and effort into putting all this data involved in some of the presentations. So if anybody has interest in that, email one of us or let us know. And that could be to just giving a presentation to I have an idea that I want to present in front of the group to go through that process. But we're certainly trying to make it as straightforward as possible.
Great. Thanks again, Jamie, for bringing that up. So with that, unless there are any other pressing issues, I want to thank everyone for their time this evening. And again, a lot of things are moving very quickly with the QC. We want to thank all of you who are participating, especially the clinicians, especially our foundation partners. We couldn't do this without you. And I think everyone is really going to benefit from this. Just to remind everyone, join us this October at the ACS in San Diego. And if any issues, contact myself, Mike, or Shelby. But again, thank you for your time, and it was much appreciated.
Thanks, everybody. Have a great night.
Bye-bye.